Thank you very much for the opportunity to join you here today. It's clear that you have got some wonderful people working on your behalf and on behalf of the patients out there, and I wish you all the best of luck. So, I think the slides are going to come up. Okay. So I guess there's been a lot of talk about the big picture, and I've been asked to address, I guess, something quite specific. And I think what you'll find is that what we'll be talking about over the next half an hour or so, perhaps it's not so specific, and perhaps we can actually start to think about it not just as the nitty-gritty of how medicines are used, but actually it reflects what people are doing with their respiratory illness, and it's really an indicator of some other things that might be going on. So, inhaler technique and adherence, you know, we think of that as being the when we use the medications and how the medications are used. But let's think of someone like Biljana, who perhaps does or doesn't have a family history of respiratory illness, who comes in and she has some symptoms. And in the ideal world, there'll be an investigation of the history of her symptoms, how they present, what they are. She might have some lung function testing done. She might have some other tests done that will look to see whether there's an alternative diagnosis. She might have further testing of the lungs, some allergy testing, and she might have some lung gases tested. And she'll be diagnosed with something like asthma, and then she'll be put on a trial of treatment. So it might be an inhaled corticosteroid plus a reliever medication, which is what would be the standard treatment. And her doctor will probably call her back in anywhere between a month and 3 months to see how she's going. And she will get reviewed, and hopefully that medication or any lifestyle changes will be recommended and adjusted. And then she will hopefully be followed up over time to see how she's going on that treatment. Any fine-tuning will happen, and her response to the treatment and any lifestyle changes will be reviewed. And it's probably at that point in time that we might expect that if things aren't going as they should, she'll come back and she'll have some symptoms, and then the doctor will have to decide, is there time for an adjustment of treatment? Or perhaps is there something that's leading to her symptoms other than that, leading to her symptoms being uncontrolled? Or does she have severe asthma? That all sounds quite structured, but of course we know that in real life things don't necessarily happen that way. And it's not always difficult to see what is the response to treatment, and why is that? I'm going to report on 2 studies that were done in primary care. So people that were, one study was done people who were visiting the community pharmacy, and another study was done people who were visiting a general practitioner. The first one, if we have a look at, so this is about 500 patients were in this first study in community pharmacy. These are all people who were diagnosed with asthma and had been prescribed some sort of treatment for their asthma. And what we found was that a very high proportion of them still were experiencing symptoms. In fact, over 3/4 of them were still experiencing symptoms. What we also found based on dispensing records, so this is the number of times they had gone to the pharmacy to pick up their medications, that 90% of them had not been regularly enough to indicate that they were actually using their medications on a daily basis. And at the same time, when we looked at how many of them were actually using the inhalers properly, we found that depending on which device, a huge proportion of them actually weren't using the inhalers properly either. Then we looked at another study that was done with about 300 patients who were visiting their general practitioner. And what we found there was, once again, there was a very high proportion of patients who were living with symptoms. And when we looked to see how they were using their inhalers, we found that almost 3/4 of them were making up to 5 errors when they were handling their inhalers. So I guess what we see is that a lot of people do continue to have symptoms, even once they're diagnosed, even once the treatment has been initiated. And very often we see at the same time that they're not using their medications regularly, and we're also seeing that they're not using them properly. How do the international guidelines, I bring up GINA guidelines here, how do the guidelines suggest that we should look at these things? Well, the guidelines suggest that we should look at it based on symptoms and whether symptoms are being presented to the healthcare professionals and whether they're being controlled. They talk about having long-term goals of good control of their symptoms with minimum medication use. So in order to decrease the risk of exacerbations of symptoms, to improve lung function, and also to decrease side effects of the medications. They talk about basing the decisions on evidence, of course, and they talk about looking at patient goals so that there is a partnership between healthcare and the patient in terms of the goals that they want to achieve. And they talk about the communication skills of healthcare professionals to ensure that patients feel comfortable and are happy with the care that they receive, and that's considered to be an important part of outcomes. And then they talk about really understanding the patient and their condition better. They talk about understanding patient preferences, and they talk about practical issues. And this is where they include inhaler technique and adherence. So in all the recommendations, you know, inhaler technique and adherence is considered a practical issue. But what I'd like to do for the rest of this talk is actually show you that it's much more than a practical issue, and actually it probably touches on all those things that come before we actually start talking about the practical issues. And why is that? And I guess some of this we've already covered, because patients have flare-ups, because we sometimes don't know why, because in addition to how they're using medicines, we have to look at whether there might be another diagnosis, there might be a comorbidity, and allergic rhinitis or hay fever is a really big one in Australia. I don't know whether that's the case here. And whether there's triggers that patients are exposed to. And also, in some ways, we might know what patients need to do, but we need to carefully investigate whether it's just about that and whether we are able to get patients to do what we feel they need to do. That is often a challenge. And why? So let's have a look at these so-called practical issues. Adherence. So in the literature, in the research literature over the many, many decades that adherence has been studied, where we're at the moment is that adherence is the extent to which a patient's behaviour matches the agreed recommendations from the healthcare professional. And that is agreed because there needs to be some sort of a discussion with the patient that this is actually the most appropriate and the best thing for them. Now, as mentioned, we know that a very high proportion of people don't take their medication regularly, which they need to do for a condition such as asthma. But why is that the case? Is it that they don't want to? Is it that they're not able to? Is it that they can't remember to? Is it that they can't afford to? It is complex, and if we do want to try and improve that, we really do need to understand why. Now, more recently in the literature, there's been this discussion about what is adherence. Once again, as an example in asthma, a patient should be taking their inhaler morning and night, mostly, for most of the inhalers, every single day. But we know that being non-adherent is not just about not taking your medication every day. It might be associated with not starting to take your medication, so not initiating after you've been prescribed medication. It might be about not persisting, and it might be about discontinuing early. So we need to understand what that actually means. And the other thing is, there is no typical person who is non-adherent. So we can't necessarily just say it applies to everyone. In trying to understand why patients may not be adherent to their medication, there's been some work done in the psychological literature, and I think this is really important and interesting to keep at the back of our minds as a framework of what might help us understand. So in this research, or in this conceptual framework, Rob Horn and his colleagues suggested that, in particular in asthma, it comes down to the weighting of two very important concepts. The first one is the patient's perception of the need to take that treatment. Do they really believe that they need to take that treatment? Do they really believe that they need to take it all the time? It's obvious that they need to take it when they're experiencing symptoms, when they're unwell. But what about when they're feeling well? And that is linked up to their perceptions of their illness, the symptoms that they're experiencing, and how they expect their illness will go. For example, something that we notice in practice is that patients get used to having some level of symptoms. They think that that's normal for a person who has asthma. They don't expect that they could live symptom-free. And the other flip side of that is the concerns they have about using that medication. The concerns about the side effects and what the side effects are going to do to them long term. And this is particularly obvious and evident in children, where parents have concerns about using medications long term, especially inhaled corticosteroids, which we know are so incredibly effective and safe, but parents in particular have concerns about giving their children this medication on a daily basis. And so then there's a negative association with the use of medicines. And underneath all that is, I guess, the contextual issues of past experiences, views of seeing others and the advice that they might be giving or getting, and practical difficulties, how to use it sometimes. Now, when we've looked at these sort of frameworks in real life and we've spoken to patients, what have we found? Something very similar. When we tried to find out what were the reasons that people were being non-adherent, we found that necessities, concerns, their acceptance that the condition that they might have is chronic and that it's not going to go away, their motivation, the ease of use of their medicines, and their satisfaction with asthma management. So what can work? What can we do that can help? And a review of much of the research has identified that there are many studies in this area of adherence. In fact, up to 93 different types of interventions to improve adherence have been studied. And the next slide really shows just the whole range of different kinds of interventions that have been tried. I mean, adherence has been an issue for a really, really long time. And I've just highlighted some of the examples. Increased information, using technology to monitor or remind people, appointments and prescription refills, trying to use different medication formulations to see whether people might be more inclined to use it, health mentoring, augmented services, and even cognitive behavioural therapy. And does any of this work? Well, only a third of all these interventions that have been tried have worked. Reminders might work for those people who forget, but we know that there are many more reasons why people don't necessarily use their medicines. So reminders aren't necessarily going to help all people or patients. And really, those things that have worked have been a multifactorial or multiple approaches looking at different things and a range of different ways of working with people for them to take their medicine. So what about inhaler technique? So we mentioned that inhaler technique is an issue. Now, up to 90% of people don't use their inhalers correctly, and this is an issue across the broad range of inhalers that are available. Some errors are more likely to be related to poor asthma control. So when we've studied the different types of errors that people make, there's some really obvious ones. For example, if they don't shake their inhaler, it's not going to mix up the medication. That's a very common error. But an error that has been found to be more important for asthma control is one that involves the way in which people exhale and inhale while using an inhaler. So we do know that there are some steps that perhaps are more important. We do know that some devices are more intuitive to use than others. So should we be looking at them? And once an individual has learnt how to use an inhaler, and we know that we can train 9 out of 10 people, in fact, we can train 99 out of 100 people to use any particular inhaler, then we know that if they switch to another inhaler, it's easier. They've already got some with some experience. So it should be straightforward, but it's not. So what can we do about inhaler technique? Can we train people how to use inhalers? And yes, we can. But we need to use the right method to train them. And written information, even with pictures, doesn't work. What we really need to be doing is, as healthcare professionals, we need to have a placebo inhaler, and we actually need to do all the steps of how that inhaler needs to be used. We need to take them through that with a device itself. The other thing we know is that education about inhaler devices needs to be repeated. So in this study, when patients came in, we had about 15% of people were able to use their inhaler. We did a one-on-one session where we showed them how to use the inhalers with repeated instructions. So you show a patient how to use their inhaler with a device, then you need to ask them, can you please show me how you would use that inhaler? Then you might need to refine that, focusing on the things they get wrong. We were able to take that up to, through that educational session, we were able to take it up to 100% of people getting it right. But when we brought them back after a month, we found that the proportion of people having correct technique went down again, went down to 60%. So 40% of people needed to be retrained. Unfortunately, when we first train them, we can't predict who those people are going to be. And unfortunately, people don't like to keep talking about their inhalers and their medicines and the things they're doing wrong. And that's a real practical issue for healthcare professionals, because they're constantly saying, oh, you can do it better. Let's try this. What happens when we train people over time? So this is a graph that shows how many times people need to be trained in one session. So at the we looked at followed people for up to 6 months, and they came back every month, and then we left them for 3 months, and they came back then after the 6 months. And we trained them from the beginning. So as you can see at the beginning, because no one was getting it right, everyone needed to be trained. The first time, most people, about half the people, only needed to be trained once. So over time, you can see that more and more people are coming back with correct technique. But what you can see is that if we leave them for 3 months, there's a drop-off again. And this is for 2 different types of inhalers. Now, does that matter in terms of their asthma control? And I would suggest that yes, it does. Because what we also did in this study was we looked at people's level of asthma control. And at the time, it was called mild, moderate, severe. Now the nomenclature is a bit different, but that's what was used at the time. So what we found was, and this is at 1 month, 2 months, 3 months, and then at 6 months. And this was an intervention that was just about technique, nothing else. And what we found was that there was a very low proportion of people whose asthma was considered mild. And this increased over time. And after 3 months, as this dropped off, so did this. So there is obviously some link there that if we can get it right, it's going to make a difference, but we're not going to get it right for everyone. And how long does it take to train someone? And this is once again that same study in looking how many minutes it took. And really, when they first started, it was taking about 6 minutes. By the end, on average, it was under 2 minutes. So for an intervention that takes a few minutes, we're seeing that people can have a significant improvement in their asthma control. That is pretty cost effective. And any government that is looking at that would say that's a pretty good investment in time. But we haven't cracked it, because in addition to what we see with people coming back with incorrect handling of their devices, 73% of people perceive that their inhaler technique is good or excellent. Over 80% of people will say that they think their inhaler is easy to use. So we can't rely on patients coming back and telling us, I need help. And over 90% of people do not have their inhaler technique checked. There are so many things to deal with that tends to fall off. And the other thing which I mentioned before, which I think is really important, is when we talk to our pharmacists and pharmacists showing people how to use their inhalers, what they find is that, you know, if people are thinking that everything's good, they get annoyed with the pharmacist asking them about their medications. And in fact, our pharmacists are telling us that they're changing their behaviour because they can see the minute they start talking about it, patients switch off. So why? Why are people not using their inhalers correctly over time? Well, we were obviously very interested in that because we wanted to try and help healthcare professionals understand this better, and we wanted to try and help healthcare professionals understand and see why some people may need to be retrained and others don't. Rather than look to retrain everyone, if there are some hints of those people who will come back with correct technique compared to those that won't, that will really help healthcare professionals. So we looked at a range of things which included patient-related factors, device-related factors, and things around whether they'd received instructions and things beforehand. And we found that it came down to three things. The person's level of asthma control. In fact, if people were well controlled at the beginning, they were more likely to maintain technique. Well-controlled people were more likely to maintain technique. That might seem counterintuitive because you might think if people are coming back with symptoms, they're looking to see what could help them and perhaps technique they might see as an answer. But actually it wasn't. It was people who were already well controlled. And we think that might have to do with perhaps this is a cohort of people that are very motivated already. They're doing everything they can for their asthma and they're trying to do more. It was linked to the type of inhaler, so some inhalers were easier to use than others, and also it was linked to motivation for correct technique. And we explored that a little bit further and found that actually it came down to something a bit more fundamental. The first thing that it was related to was the patient's perception of the threat of their asthma. So, if people were experiencing symptoms, they thought that their asthma was a threat, then they were more likely to maintain technique. And if you think about it, those factors relate to that concept of necessity. People who believed that by using the medicines they were going to get better, they believed in the process of self-managing and using these medicines, were more likely to maintain technique. So this was about their threat of asthma, but also about their concerns and the side effects that they were experiencing through inhalers, through the use of inhalers. So once again, you can see that these things can be related to concerns. This is with regards to maintaining technique. So you might be thinking, oh yes, that's familiar because we were just talking about adherence. Now we're talking about it in terms of maintaining correct technique. And the final piece of the puzzle was what they felt about their own ability to manage their illness. So this was about general lifestyle stresses and how the asthma and their management of their asthma fitted in with other things. What is it a priority? For parents, it's often, their own asthma is often not a priority because they have other things going on which they see as priorities. And that might be linked to whether they have support, it might be linked to some other issues, it might be linked to practical issues. So these three things were found to be related to inhaler technique maintenance. So I'd like to suggest that, you know, we think about inhaler technique not just as a physical skill, but as more than that, as a complex process, and one that is intrinsically linked to how people feel about their condition and managing their condition. Fixing the problem hasn't been so easy when we've just focused on technique, so maybe we need to think about this differently. And I would question, should we think about how one uses their medication and when they use it together? So should we be always considering inhaler technique and adherence as one package? And why should we do that? Well, because they do seem to coexist. And that was that first data that we showed. And some preliminary research that we tried to correlate different factors with inhaler technique maintenance, and this was done in a larger cohort of patients, was that adherence over the last week predicted whether patients maintained their technique. So if you ask a patient about how they've used their inhaler in the last week, if you identify that they haven't used it regularly, that individual is the one that is more likely to have problems maintaining technique. And now we've actually got more refined ways of understanding the issues. That is, there's now new technologies available within inhalers. These are at the moment still in investigation, but they're looking to be implemented in new inhalers, which will help us understand whether a person, how regularly they're using their inhaler and whether they're using it correctly. Because of course that is going to really impact on whether the person is getting the right amount of medication. And this is a particular device that uses sound, and it's a digital device which will record the time at which an inhaler is taken, and based on sound waves, it actually can tell whether the technique has been correct. So it's really, really cool, and it can help a healthcare professional use it as perhaps to explain to a patient how they're going, but it also gives us insight. You know, if a person's not using it properly and they only use it once a week or 3 times a week, obviously that particular medicine isn't going to be working for them. And so the other reason why we should be looking at it is because we now know that all these factors are linked to both. So in thinking about that, what do we need to further consider? Well, we need to consider that some devices will be more intuitively used or more favourable, and perhaps they're the ones that we should be going for. But we also need to consider that there's special populations who will have special needs, and we can't use the same approach of training or motivation for all of them. And in particular, we have been looking at people with intellectual disability, and we're now focusing quite a lot of attention on elderly and people with cognitive impairment, because we know that when it comes to even things like sequencing of events, as people start to have cognitive impairment, they get those sequence of events mixed up. So for example, with the turbuhaler, one of the inhalers, you need to twist the base at the bottom because that loads the inhaler, and then inhale. It's been shown that people with cognitive impairment sometimes inhale and then they click the base, which obviously means they're not getting a dose. We also need to think about what happens in childhood, and are there things that expectations that are being developed in childhood that might give children a framework for the use of medicines. So for example, if a parent believes that the child doesn't need a medication regularly, if they're worried about the side effects, if they're happy for their child to only use their medication occasionally, is that setting up a framework of expectations for that individual later on? A lot of people have had asthma their whole lives, so when they come into a healthcare professional at the age of 25 or 30 and you want to engage with them, I've had it my whole life, I know what I'm doing. And they do know their asthma very well, but they may also be living with symptoms that they're not aware of. And perception of symptoms is also a really big issue for some of these conditions. So how can we help? So I feel I need to finish off with some solutions for you. And the solutions that we have looked at are related to these things. The first one is healthcare professionals working together. The second one is understanding patient perspectives a bit better. And the third one is trying to look at ways in which we can help special populations. At one stage, we got some funding to look at interprofessional care. And we decided to, in many ways, really focus it to the bare minimum of inhaler technique. If we do need to repeat inhaler technique training, if every healthcare professional that person engages with does it, well then we're all contributing to the same thing. And while this research was really important for inhaler technique, this research was also really important because we used it as a platform to try and build interprofessional relationships. And in this particular study, we looked at what are the different ways that we can train healthcare professionals together to help them be on the same page. And the first thing that we looked at is we brought them together and we did hands-on training where they paired up and worked with each other. The second one was using technologies, because a lot of education these days for healthcare professionals is online. And the third one is going back to some theories of relationships, which really the model that we used was a model called the sociocultural theory. And this is about people from different cultures, in this way, different health cultures, coming together and learning about each other through education. So that project was done with 300 patients in the end, and we looked at the relationships as well. The other thing was understanding patient perspectives, because as part of healthcare professionals working together, we often feel that we have quite a lot of influence with patients. We know that they have other influences, but we like to think that they do take our advice seriously and that it's meaningful to them. So we decided to look at patients who had asthma, these were adults, and we used social network theory to draw health maps. First of all, to identify who people spoke to around their asthma and what they spoke to them about and how that influenced what they did. And this is an example of what the individual's healthcare maps looked like. With the individual, and this is what's called an egocentric model, because social network theory has been used in a lot of different ways, and there's different models of it. But this is one of the basic ones where it's an egocentric model, is what it's called, where the individual's in the middle, and on a series of concentric circles, they need to place individuals. And we said to them, who are the people that you talk to about your asthma? And depending on who they named, we then said, can you please place them on one of these circles, which represents how important they are in your decision-making around your asthma. And what we found is the different colours are different groupings of people. So the one person with asthma, we think they're talking to their doctor, we think they might talk to their pharmacist, there might be a nurse. Actually, there's a whole range of people that they talk to. They've always got one healthcare professional in the inner circle, but they've always got one other person, and it's a family member or friends. And they know why they're going to their doctor, and they know what to expect from their doctor. But it's their family member that lets them know when their reminds them that their asthma is getting worse. And they do rely on what they're told. In fact, some patients even said that they speak to their friends about what dose of medicine they're on. So I think we like to put all our energy into suggesting what is the optimal thing for the patient. But sometimes we may not be fulfilling another need, which might be more engagement and talking about their condition more broadly. We might get more traction there. And then finally, as I mentioned, we're doing work with people, special interest groups, which include people with intellectual disability and elderly patients. So, where do we end up? Well, I guess the decisions as healthcare professionals that we make need to be based on the best science possible, of course, but they need to be relevant for the patient. And if they're concerned about side effects, then we need to be aware of that, and that is what we need to address before we can go down to the practical issue of the when and how they're using their medicines. The other thing we need to understand is that one size does not fit all. Even if we have people with similar demographics, age, stages of life, there will be individual innate things and concerns and fears and worries and priorities that will differ. This gives us the opportunity to incorporate these things into new asthma guidelines, or reports as they're now called, because I think more and more it's being recognised that asthma guidelines are very difficult to implement as they are. So now they're starting to be referred to as evidence-based reports. It still means that it's up to us to make that link. And we have a very important opportunity with the training of our undergraduate students. And of course, with regards to interprofessional education and professional courses. So we do need to work together, and we do need to understand the fundamentals of where these issues are coming from, and know that what we see with the when and how is a reflection of what's going on underneath. Hopefully we can develop resources that play to that, and we should look towards novel inhalers and support materials. And finally, we need to somehow find a way to make discussions around medicine use engaging, exciting, and to be seen as something that patients really need to think about. Thank you very much.
Thank you, Cynthia. We have time for a few questions. Just wait for the microphone, and it would be useful if you'd maybe say who you are. This couple here, microphone. Here we are.
My name is Lou, and I'm a board member, and you've probably seen me in previous conferences, but I don't really know how to speak.
Oh, I know, but we'll have it anyway.
But I'm really, really thrilled to have heard what you've had to say. I have to tell you, when I first heard it, I was kind of stiff. But as you took us on this journey, as a chronic asthmatic myself, it was great, because where we ended answered a lot of questions I had on the way. So just this little share, as it is a chronic asthmatic, like I've just said, that over the years I've had significant other people in my life who happen to be, as a younger person, my parents, and now, right now, today, my husband, and they, thankfully, from a health professional, were trained, as well as I, with my asthma. So when I'm well controlled, and I know exactly what I have to do. When I am unwell with acute asthma, I lose it. And so my coach steps in, and he knows exactly what he has to calmly get me to do with technique of my medication. So thank you for that. And maybe, I don't know, if there is a thought that people on the ground, health professionals who are out there, would actually look to the significant others in our families, and it involves different cultures as well, and say, who might that be, and would you like to be trained alongside your loved one? It helped me, and I'm certain it will help a lot of other people. Thank you.
Thank you.
Here.
Smita Shah from Sydney, Australia. Thank you, Cynthia, for taking us through what I think is one of the most important issues about inhaler techniques. But you sort of delineated the patient factors. What about the role of health practitioners? Because we know, especially physicians as well as pharmacists and nurses, we're not very good at teaching on those devices. And a lot of part of the problem is not just about the patient factor, but it's actually the responsibility of the physicians to ensure that their patients use the inhaler devices correctly, as well as are able to adhere to the management that they are prescribing through good communication. Could you just tell us a bit more on that?
Thank you very much for that question, Smita. I mean, there's lots of, there's a significant amount of research that shows that healthcare professionals don't necessarily know how to use these inhalers correctly. And, I mean, it's not surprising there are many inhalers, and certainly in Australia it's surprising how few healthcare professionals get given a placebo inhaler by the pharmaceutical companies. I mean, if I was a company representative, I would be giving every single healthcare professional a placebo inhaler. Certainly, healthcare professionals need to know how to use them, and it's not just thinking they know how to use them, but actually knowing how to use them. But I sort of think that, and I mean, maybe this might be a bit controversial, but I actually think that there's one thing a little bit deeper than that, and that is that healthcare professionals don't have an absolute belief about the use of inhalers and about that technique. Now, I don't have any evidence for that, and those people that are really into inhalers and that are really into, respiratory illness and have a particular interest, those healthcare professionals, yes, they probably are really into it. But I think a lot of them think, yes, of course patients need to use their inhalers correctly and this is how you do it, but I don't think they really believe that by improving that there can be such significant gains. But I might be wrong, so I apologise if I'm wrong, but that's my kind of gut feeling that's sometimes an issue.
Just have a, not a question, but I do want to add some, just some thoughts on the great presentation that you've done. I'm Lupe Kirikoli, a community clinical nurse, long-term condition with a focus in respiratory from Mid-Central Health in Palmerston North. Anyway, I had to write them down because I get forgetful. One of them is providing a holistic assessment. We need to be asking the right questions as well. And when we do ask the questions, we've got the cultural and everything else, that we should be mindful of. And when we do provide education, we should educate appropriately to the patients, the whānaus, the communities, families that are in front of us. The message should all be, like you've said, singing the same song. Patients should never be confused at what we give. It is our fault. That they are not adhered to or comply with their treatment. So it's really up to us to do that job.
Just to add to that, I mean, really, it's our responsibility, isn't it, to find the right way.
Okay, that's it. The other one is about patients do forget, so I never give up hope that I continue to educate the patients. The care should be personalised, and I'm hearing lots of good stuff so far. I just wish that we were a bit more connected. The dots should be joined now to provide better health for New Zealanders. Thank you.
Another one over here.
I thought it was a fantastic presentation, thank you. And it highlighted something, or a question for me really, as someone who's had asthma all my life. I don't think I've ever heard asthma referred to as a chronic health condition. And I wonder whether, and this is in my interaction with health professionals over a number of years, and I wonder if that's something that actually needs to be thought about more, and particularly for healthcare professionals in general in their training. Most of the health system seems to focus on illness as something that can be treated and cured, and it's a short-term kind of interaction, it seems to me anyway. But increasingly healthcare is having to focus on chronic health conditions. Asthma is one of those, and yet it doesn't seem to, as I said, the health system itself doesn't seem to have a sort of a general understanding of chronic and how that should be managed, whatever the condition is. So I wonder if that's something to think about.
I think that's a really good and a very important point, pardon me, and one that, that might come back to what happens with children and their parents and how they see it. I mean, certainly in Australia at one stage there was a lot of hesitation in diagnosing and actually saying that the child definitely had asthma. And I think, probably as a parent you hold on to the hope that maybe your child doesn't have something that's going to be chronic. And secondly, there's still perceptions that if you don't have symptoms, you don't have asthma at that time, but when you do have symptoms, then you do have the asthma. And so I think that's a really, that's a really important point. Maybe sometimes doctors think that if they say asthma, people would just naturally understand it's a chronic illness. Whereas, that hasn't maybe actually been said. So that's a very important point. Thank you for raising it.
Very nice question here, thank you.
Oh, kia ora. Cameron Muriwai from Bronchiectasis Foundation. I'm going to take something away from your presentation, and it is when you said that pictures and words do not necessarily transfer the information and the understanding. And perhaps I could relate to that. Perhaps that's because I'm Māori, I'm a Māori man, and I really do. I need it to be dismantled in front of me. I need to watch you do it, and I may need to watch you do it 10 times. But when I get it, I've got it. Now, I've struggled as a male in controlling my asthma. And I'll go from one inhaler, and I'll go up to like 5. And I will sit through a process where it is really only coming from one side of the table. And I know that I have to be patient because we will begin with 1, and then we have to trial that, and then we'll move to 2, and then we'll come back and trial. So what I do as a Māori male with asthma is that I ride this journey out, because I can see that the conversation is not across the table. So I've actually got to sit there and go through all of this journey and wait till we've got to the 5th one, and then have my say then. And then we begin to come back to what we really needed to do. And it, so I guess it's about being heard in the relationship. My respect to the prescriber, to the clinician, but my need for my voice to be heard in something which is very old, and we call it whanaungatanga, a relationship. And once we have that, then we can discover many things about asthma and other conditions. But I want us to hear that piece of the message, that pictures and words alone do not do it for us. Our relationship and our sitting down together and our friendship, then we can achieve many things. Kia ora.
Thank you. Yeah, well said. Okay, thank you.
I invite Lois now to thank our speaker. Thank you, Cynthia.
Can you hear me? Yes, cool. Cynthia, thank you. It is my honour to be able to stand up here. I actually think I'm redundant because, quite frankly, the questions and the comments from the audience today, so they have been involved with what you've been doing. But the things for me that really popped out were just 2 or 3 that really stuck with me, that big pictures are made of many small things, and those small things, like relationships and all the other bits and pieces and understanding, are very, very important, and I think we will all take that away today. Tell, show, educate, retrain, do all of that kind of stuff. The thing that is really important to me from my past and experiences is about asking the right questions in a positive way, which says you are interested, and I think that is huge. So thank you very much. It's been a wonderful, wonderful speech. Thank you.